Well, no, you're good. We're going to go ahead and get started. We have many folks on Zoom and a few folks in person. Hopefully more will show up, but thank you all so much for being here. My name is Hannah Weaver. I'm one of the inpatient chief residents. We are very lucky today to have Dr. Helen Chu speaking to us. She is a physician scientist, professor of medicine and epidemiology, and associate dean for research at the University of Washington Schools of Medicine and Public Health. She studies respiratory viruses and vaccines and has conducted observational and interventional studies of vaccines and therapeutics, including maternal influenza vaccines in Nepal, SARS-CoV-2 and influenza vaccines in the US, and antivirals for treatment of influenza and COVID-19. She has also conducted research on maternal immunization for respiratory viruses, including studies characterizing maternal fetal immunity against respiratory syncytial virus and influenza, as well as studied correlates of protection against respiratory viruses. As principal investigator of the Seattle flu study, she helped design a prototype pandemic preparedness platform and first identified COVID-19 community transmission in the US and accelerated the public health response to the pandemic. She has published over 250 papers and has received funding from the NIH, CDC, and the Bill and Melinda Gates Foundation. She is a member of national and international committees on respiratory viruses and vaccines. She has given invited talks to the Food and Drug Administration and the World Health Organization, and has served as a voting member on the Centers for Disease Control Advisory Committee on Immunization Practices, as well as the chair of Maternal Pediatric RSV Working Group. She is a fellow of the Infectious Disease Society of America and a member of the American Society of Clinical Investigation. She serves as an associate editor for the Journal of Infectious Disease. Please welcome Dr. Helen Chu.
Thank you for that very nice introduction. I'm really happy to be here today to talk to you about one of my very favorite topics, vaccines. And it seems like I finished the talk and then the next day something shows up in the news about some major federal policy change. So this is up to date as of 24 hours ago, but I don't know what's happened this morning. So here are my disclosures. Oh, I don't think this is the right slide deck. Oh, you're right, I did not. So let me, I do have my laptop with me. Maybe I'll go ahead and let you swap out the slide deck, and then while you're doing that, I can keep on going. Good. Sorry, let me. Yes. Okay. So we have, I think we're going to swap out the slide decks real quick, but maybe I'll just go ahead and keep on going for now. So I wanted to start first with the clinical scenario, and the clinical scenario that we decided to use for a piece that we wrote recently was about access to COVID vaccines for young children. And so it is fall of 2025. The US government makes it confusing and difficult for children to get vaccines. 3 healthy children live with an immunocompromised relative, but the family can't afford the vaccines. And after the holidays, one of the children gets COVID-19, exposing the immunocompromised relative and the children's grandparents, some of whom are later hospitalized with severe infection. I think some parts of this have changed. We now have an individual decision-making recommendation, not a complete, I think, lack of recommendation for COVID vaccines in young children. But I think what we've seen play out is actually that COVID vaccine uptake, especially for young children, has gone down precipitously since these changes have started being made at the federal level. So in this talk, I wanted to talk about the history of vaccine policy in the United States, the current state of vaccines and the future of vaccines and what can be done. And my goal at the end of this is that you have an understanding of the history and rationale underlying vaccine policy guidelines and how we might work to reinstate them in the future. And several of these slides are courtesy of Sean O'Leary, who is the infectious disease liaison for the American Academy of Pediatrics. So vaccines in the United States started with the American Academy of Pediatrics. They were the main body that made vaccine recommendations and published them in something called the Red Book, which you can see here on the right. And one of the first things that they published was in 1935, and it was the forerunner, which to the Red Book, which was the 6-page routine measures for the prophylaxis of communicable diseases. And it really only focused on 4 infections, the 4 infections that caused severe disease in young children at the time. And that was including smallpox, diphtheria, tetanus, and pertussis. So after that, what happened was that there was the golden age of vaccine development in the United States in the 1950s and 1960s with the advent of tissue culture and the use of tissue culture for growth of viruses. So the Nobel Prize was awarded to Weller, Enders, and Robbins in the 1960s for their growth of poliovirus thank you for swapping that out, for the growth of poliovirus in 1949. And then after that, what happened was that there were a lot of vaccines that were licensed in rapid succession: poliovirus vaccine, measles, mumps, and rubella. If looking back at the time, the 1940s and the 1950s was really a time of panic for the general public. Because of these annual polio epidemics, schools were delayed or closed, entire towns restricted entry of children, and individuals were placed in isolation and quarantine. And this was very much like the early days of the COVID-19 pandemic. And here is a curve showing polio cases. You can see in the 1910s, 1920s, there were spikes, and these numbers of spikes increased exponentially over the course of the 1940s and the 1950s, until finally the introduction of the vaccine in 1955. And that led to a dramatic drop in the number of cases. And it was clear that the general public was able to see that there was a direct impact on cases and deaths as a result of vaccine rollout. During this time, there was also a lot of public, I think, enthusiasm and optimism for vaccines. Here you can see Elvis Presley receiving his poliovirus vaccine to encourage teenagers to get vaccinated. And you can see the lines of people waiting to get their poliovirus vaccines. Again, very reminiscent of the early days of COVID-19. What happened shortly after the licensure of the poliovirus vaccine was something called the Cutter incident. I don't know how many of you have read this book by Paul Offit, which details what happened at this time. And it was really at the beginning of some of the issues that led to regulations for vaccine safety in the United States. So Cutter Labs was located in Berkeley, California. They were one of the first groups to make poliovirus vaccine. And there were some issues with formaldehyde inactivation of the virus they used. So the vaccine that they ended up administering to 200,000 individuals was a partially inactivated vaccine. And children who were given Cutter's vaccine actually developed more severe disease than had they acquired natural polio. So they were more likely to be paralyzed in their arms, more likely to suffer severe and permanent paralysis, more likely to require breathing assistance and iron lungs, and more likely to die than children who are naturally infected. So the timeline of events with the Cutter incident started in April of 1955, where the first infant received the vaccine. And then 9 days later, was admitted to a hospital in Chicago with paralytic polio. The next day, 5 more cases were identified, and ultimately 200,000 people were given this live partially inactivated vaccine, of which 70,000 became ill, 200 were permanently paralyzed, and 10 died. And this was really a reckoning, I think, for the beginning of sort of the golden age of vaccines. What happened was that this led to multiple lawsuits against vaccine manufacturers and a ruling of liability without fault. So the California Supreme Court ruled that Cutter Labs was not negligent in their vaccine manufacturing, but they were financially responsible to the families for the deaths that occurred due to this vaccine that they received. And as a result of this, many pharmaceutical companies chose at the time to stop making vaccines. They decided that it was not worth the risk of making these vaccines and being sued for making them and administering them. And because of this, there were actually a lot of regulatory safeguards that were put in place. Regulatory safeguards, I think, that are now being challenged. So it's important to understand how they were put in place and why they were put in place. So there was a creation of the Division of Biological Standards, which is now the FDA Center for Biologics Evaluation and Research. And this tremendously increased FDA oversight of the vaccine licensure process. And it increased oversight not just of the clinical trials themselves, but also increased oversight of the manufacturing process. So you not only had to prove that your vaccines were safe and effective, but that they were manufactured in a facility that could guarantee that each lot was manufactured correctly, that the labels remained correctly, that the stopper was correct, that everything, the diluent that was put in the vials had been QC'd. So the entire process end to end had to be part of the licensure process for a vaccine. Importantly, one of the other things that this led to was the establishment of something called the Vaccine Court. And I'm sure you've seen a lot about this in the news lately. This was part of the National Vaccine Injury Compensation Program. And this was meant to place a tax on every single vaccine that was purchased. And this tax would then be fed into this common bucket, which was then used to fund the vaccine court. And this compensated people who were injured by vaccines on a no-fault basis. So what that meant was that the vaccine manufacturers themselves would not be sued, but each case of an adverse event would be brought to this vaccine court, and the people who sued would then be given compensation from this vaccine court. And the result of this was that it stabilized the vaccine market. It allowed pharmaceutical companies to continue to make vaccines. This is an example of a vaccine injury table from the vaccine court. So for example, if you were to develop brachial neuritis after receiving a tetanus vaccine in the 2 to 28 day period after receipt of the vaccine, then that is a known injury, and you would be compensated based on that. Looking at this, I think one of the main things that comes to mind is that if it is a new vaccine or an previously undescribed injury, then actually, if it's not on this table, it's actually very hard to get that compensated. And it's really up to the person with the injury to provide the proof to be able to get the compensation from the injury that they received. The other thing to know is that the COVID vaccines were not part of the Vaccine Injury Compensation Program, that they were handled separately in something called the CICP, the COVID Injury Compensation Program. And this had a 1-year statute. So people had a lot of issue with this, with the fact that COVID vaccines were handled separately from the VICP. One of the things that has come up recently in the news, which you may recognize, is that HHS wants to add autism as one of the injuries from vaccines to this vaccine injury table. And if autism is added here and people were able to say that autism was a result of the vaccine that they received, then basically that would bankrupt this entire system, and we would no longer be able to pay out for adverse events related to vaccines. Another thing that happened in the 1960s was the formation of the ACIP, the Advisory Committee on Immunization Practices. As I just showed, you had all these new vaccines that were coming, MMR, polio, and what happened was that each one had to be evaluated by a separate committee, and that became untenable very quickly. And so what happened was the ACIP was really charged with the responsibility to harmonize all of these vaccines. And the first meeting was held at the CDC in May of 1964, and it was chaired by the CDC director. And the ultimate goal of the ACIP was to create a single unified vaccine schedule and to harmonize with the American Academy of Pediatrics schedule. Another important thing that was created was the Vaccines for Children program, and this happened in 1993. Much like now, measles outbreaks were happening in the communities. It was noted that these were happening in low-income communities who did not have access to affordable vaccines. And so the VFC program was created actually by Kennedy through an act of Congress, and it provided vaccines at no cost to eligible children under 19 years of age. And this was a surprising statistic to me, actually, that half of the children between 19 and 35 months of age in the United States fell into this category, that they were covered by the VFC. These are Medicaid eligible children, American Indian, Alaska Native children, and uninsured or underinsured children. And the funding is allocated through CMS to CDC, and then they purchase these vaccines in bulk and they distribute them to VFC providers. And what this did was that it created a stable vaccine pipeline. So all children in the United States could receive vaccines and you would be able to achieve herd immunity. And ultimately, what this led to was a harmonized childhood immunization schedule. This is the 1995 schedule. It's a schedule that was harmonized between ACIP and American Academy of Pediatrics. And I think it's important to show this schedule because this is the schedule that many people who are having children now remember having received when they were children. And so it just goes to show perhaps why parents are so concerned now as they look at the current schedule and compare it to what they received as a child and see a vast difference both in the complexity and the number of vaccines that their children are receiving compared to ones that they remember receiving. Okay, so that's more of the history, and now I wanted to move to the current state. Up when I say the current state, I meant up until summer of 2025. And so for many of us here, we understand that every stage of the vaccine life cycle involves scientific rigor, attention to detail, and an evaluation of the safety process. So what happens with vaccine licensure and recommendation in the United States is that first you do the basic research, the preclinical studies, and at that point, an investigational new drug application is submitted to the FDA. The FDA approves this IND, and then that is what allows you to go forward into the phase 1, 2, and 3 clinical trials. Oftentimes, your protocol for your clinical trials is decided in concert with the FDA, which is why that recent ruling a few days ago against the Moderna mRNA flu vaccine was surprising because they declined to review at actually a much later stage, but the FDA had actually been involved that entire time in deciding how they were going to conduct the trial. So then after the phase 1, phase 2, phase 3 trials are conducted, a biological license application is submitted, FDA is reviewed. FDA's focus is on safety, efficacy, and then also the manufacturing process. After that, FDA approves a new vaccine. Once a vaccine is approved by FDA, it does not mean it's going to be paid for by health insurance. That requires ACIP review. So a vaccine is then reviewed by the ACIP, and the ACIP's determination is really, is this vaccine going to be used in the right people for the right indication? So FDA could approve a vaccine or license a vaccine, but if CDC does not recommend it, it's not going to be covered by health insurance or vaccines for children. Once it has the ACIP recommendation, then it is published in what's called the MMWR, the Morbidity and Mortality Weekly Review. It's signed off by the CDC director and then by the HHS director, and then it is required to be covered by health insurance, and people in the United States can receive it according to the way that it has been recommended by the ACIP. After all of this happens, then this moves on to post-licensure, post-recommendation monitoring. And this is where platforms like the Vaccine Safety Data Link come into play. So these are large networks of managed care organizations like Kaiser, where they feed data into the system, and there's rapid review of the data to make sure that the safety signals or lack of safety signals that were seen in the clinical trials are not seen in the post-licensure period. And so this data is reviewed in real time at meetings every few months. And then if there is a safety signal that arises in this period, then we go back and we revise the recommendations and we revise the approval. So it's an iterative process that occurs both before and after vaccine licensure and recommendation. The ACIP was up until very recently a fairly obscure panel, but now is no longer an obscure panel. So it used to have 15 voting members. The idea was that this was a group that is external to the government, so mostly in academics, in public health, with varying levels of expertise in these different subjects. And the idea was that people serve in overlapping terms so that at any one point, there's always somebody on the committee who has been there for a few years and understands procedure. There are public meetings. The data is presented by CDC staff. The data is reviewed in an open and transparent manner, and then there's careful deliberation of the evidence. And then 2 votes are taken. And this, if you've watched any of these meetings, you'll see that this was actually a point of confusion recently. So first you take a vote for recommendation, and then you take a vote to whether or not vaccines for children will be paid for. So it's called a resolution for VFC. goes to the CDC director and then the HHS. There's an extensive conflicts of interest screening process as part of this. I just wanted to comment a little bit on this because I think it's important. So to be able to serve on the ACIP, you really do need to have experience in conducting clinical trials. And I mean, in the United States, many clinical trials are funded by pharma. So most of the people who do serve on the ACIP have had experience running clinical trials and pharmaceutical funded clinical trials. It's impossible to find people who have no experience in that. And you actually don't want those people to be serving on the committee because you want people to understand how the trials are done and how to interpret the adverse events. So there is a time period, I think it's 2 years before that you start the vetting process. And then as you join the ACIP, you have divested of all of your conflicts and you have no conflicts while you serve on ACIP. Because the subject matter experts or the individuals who are voting on the ACIP are not necessarily all going to be subject matter experts, there's also an extensive group of other people who help the CDC, ACIP make decisions, and this includes FDA, NIH, subject matter experts, immunization safety officers, a lot of people, but only the 14, 15 members of the ACIP vote on the vaccines. I think it's also important to understand the difference between federal and state in terms of oversight of vaccines, because this comes up a lot, especially I'm sure people ask you, why do we have mandates and all of those things. So what the federal government, as I just outlined, does is they do the safety and efficacy, they do licensure and recommendation, they do the post-marketing surveillance, and they develop national guidelines. And because these national guidelines are tied to health insurance, the Affordable Care Act mandates that vaccines that are recommended by ACIP are covered by health insurance. And then they fund and administer the VFC program and oversee the vaccine court. The state governments, on the other hand, are the ones who set vaccine requirements and mandates. And I think this is helpful, especially for us in the state of Washington, because the mandates and the requirements are actually set at the state level, not at the federal level. And it also, the states have a lot of autonomy in determining which guidelines and recommendations to follow. And one of the other things that the states do is they regulate healthcare worker immunization scope of practice. So for example, if a pharmacist can administer a vaccine, and that's really important because I think we know that many vaccines, particularly adult vaccines, are now administered in pharmacies. And then they have the authority to require state regulated insurance to cover vaccines. I am still not clear, and I've tried to get the answer of what happens if there is a discrepancy between a recommendation for a pediatric vaccine, for vaccines for children, and what the state wants to cover, and who pays the difference. And I don't know the answer to that question. I don't know that there is an answer to that question, but I think that's something that's, I think everyone's worried about. And then, of course, the states collect the data and send it to the federal government. One of the other things I think is surprising to a lot of people is how expensive vaccines are. So this is the cost of vaccines. And so here, for example, you can see that the hepatitis A pediatric vaccine is $22.64 for CDC cost per dose, whereas the private sector cost is $36. I can tell you with the more recent vaccines like the RSV monoclonals for babies, that cost is $450. So that is a tremendous cost. In other countries, there is a much larger difference between the federal cost and the private sector cost. In the United States, for whatever reason, those numbers tend to align a lot more, that we don't use the purchasing power of half the vaccines in the United States for children to leverage that to negotiate the cost down in the same way that other countries have been able to do so. And so what this means then, of course, is that vaccines are very, very expensive. And this is the most recent data actually that I could find, but here you can just see that, in 1986, there were 5 recommended vaccines and that cost $215. And as of 2014, it cost $1,255 per child to get their childhood vaccines. And that number has, of course, gone up even more exponentially. The other more recent event, as all of us know, is that the anti-vaccine movement has really accelerated. The WHO declared the anti-vaccine movement one of the top 10 threats to global health in the globally, and then in the United States, it really sort of took off and then was tremendously amplified by the COVID-19 pandemic. And as a result of this, what we saw over the course of the last decade is all of this return of vaccine preventable diseases. So measles deaths, more measles, whooping cough in 2015, This year, we have twice the number of measles cases in 2026, double the number of total cases from 2025, and then also another whooping cough outbreak. So all of these diseases are now coming back. One of the things that I think Washington State has done really well is their legislation to manage a lot of these issues. So Washington State legislation was put in place in 2019 to eliminate the personal philosophical exemption for MMR vaccines, and this happened, I think, as a direct consequence of the Clark County measles outbreak. California and Vermont had recently removed their personal exceptions, so there was a precedent for that. One of the grad students in my lab was able to study this, and she was able to compare Washington to Oregon and look at uptake of MMR vaccine. And what she found was that after the passage of the bill, we saw an increase in kindergarten MMR vaccine completion rate by 5% in Washington compared to Oregon. And the overall exemptions decreased 41%. But of the ones that did still have exemptions, those who had personal philosophical seemed to have flipped over to religious exemptions. So the number of religious exemptions went up by 367%. So now this is where we were as of 2019. And then, of course, COVID-19 happened. And COVID-19 was remarkable for a lot of reasons in that we had a vaccine that was developed in record pace and that managed to save millions of lives. And this was just a graph just showing how quickly we were able to get from knowledge of the sequence back in December of 2019 to the start of the phase 1 clinical trial in March of 2020. And the fastest timeline up until then was for Zika virus vaccine, which was also tremendously fast, but it was 190 days. And of course, we all know what an impact COVID-19 vaccines had on prevention of death, just like we saw with polio. But unlike with polio, what happened with COVID-19 was just a rapid amplification of the misinformation and disinformation that occurred. And so that really brings up to where we are currently, which is that I think that what we had before, which is the vaccine regulatory framework, was very rigorous. The vaccine recommendation process was very much considered the international gold standard. And COVID-19 vaccines saved millions of lives. However, because of this, because of whatever happened with COVID, there has been misinformation, disinformation about mRNA vaccines, and this has really bled over into childhood vaccines as well. I think it's important to remember that as of now, the majority of parents continue to vaccinate their children on time according to the childhood immunization schedule. And parents do want vaccines. And I think it is just all of the messaging that's coming at them from the federal level, from the media, that's starting to put more doubt in people's minds and starting to make these numbers go down. Okay, so now that brings us up to 2025. And so here we are in 2025. So there was a post on X by Secretary Kennedy with Jay Bhattacharya and Marty McCary. Basically, I think what he decided to do at the time was to remove the recommendation for children and healthy pregnant persons for COVID-19 vaccines. They followed this up very shortly with this article in the New England Journal, basically saying that in order to have updated COVID vaccines, we needed to repeat randomized clinical trials against placebo for COVID-19 vaccines because it is no longer clear that COVID-19 vaccines continue to save lives in younger healthy adults. This was followed by a Washington Post article on June 9th, where RFK said that he was going to restore public trust in vaccines by dissolving the ACIP, and then we received our termination emails about 2 hours later telling us that we are no longer members of the ACIP. This then led to appointment of new ACIP members, including Robert Malone, who I think is vice chair of the ACIP, who has actually been very vocal and that he is indeed an anti-vaxxer. And then followed by the hiring and then firing of the new CDC director. So shortly after this happened, the first thing that we as the prior ACIP group decided to do was just to sort of sit down and try to document what was happening. So we wrote a series of perspective articles talking about the role of the ACIP and why it was important, and then talking about a path forward. And we sort of saw this as an opportunity to start coming together and providing some scientific guidance to interpretation of the new federal guidelines that were coming out. And we proposed a couple of things. So there are two things that we thought were important to think about. And the first was both the short-term solutions and then thinking about the long-term solutions. So first, I wanted to focus on the short-term solutions. The short-term solutions that we proposed include relying on other sources of data to make decision-making, to guide decision-making. This includes the Vaccine Integrity Project at the University of Minnesota, as well as professional organizations, including AAP, ACOG, and AAFP. The second thing we thought was important was for somebody to actually document the irregularities of what was happening at ACIP. And we recognized that this was happening in the media with the New York Times and the Washington Post, but it was not actually happening in a scientific manner. So we decided that we, as the prior ACIP, would take this on, and we would watch every single ACIP meeting and document all the irregularities and then publish these in scientific journals so that we had some evidence. Because the evidence from the CDC website was just starting to disappear. And then we thought that the next thing that would be the most rational thing to do at the time was to put in place state level legislation to divest from ACIP. Ultimately, what happens when you do this, though, is that you create this patchwork of states that have decided to keep vaccines and states that have decided to follow federal regulations and make vaccines more difficult to get. So these are some examples of some of the papers that we published. These were actually used as part of the filing against HHS that was successful this week, and so we were able to just start documenting all of the statements that were made during the ACIP meetings, and then to provide the evidence and to refute them. And the main things that we found to be, well, I mean, there were so many issues, but the main ones that we found to be worth highlighting were, first, that there was limited expertise in vaccinology and clinical practice. So the new members who were part of this panel were not people who had studied vaccines and they were practicing clinicians, but they were not vaccinologists. And so it was difficult for them to be able to review the data and interpret it. That there is inconsistent processes and use of low quality data. So normally what happens in these committees is that you review the evidence and you grade the evidence. You say this paper, which is an RCT with a placebo, this is something that we rely on. And this is an observational study in another country, and we don't use that in our decision making. So there wasn't vetting of the data that was coming in to make decisions. There's also a lot of lack of transparency and loss of independence. We observed during the meetings that decisions seem to have been made outside of the meeting through private discussion, which is not allowed during ACIP. And then also this very much a misplaced focus on just adverse events, that the meetings became discussions about potential deaths and SAEs that came from vaccines, but very little about benefit. And then also very little concern about access for populations or giving people choice in their vaccines. One of the things that also just happened, I think this week or last week, was the passage of a bill in Washington State, EHB 2242, which delinks Washington State from ACIP recommendations. And I think this is helpful to us for a number of reasons. It moves vaccine coverage decisions from ACIP to the Washington State Department of Health. And so the recommendations are now coming from medical experts rather than political appointees. And then it was just signed, I think, on Monday. And so the idea now is that we will have immediate implementation of this and allow us to no longer be tied to changes in federal recommendations, which I think is very helpful. And then also happened, I think, on Tuesday was that there was a lawsuit that was filed by the American Academy of Pediatrics and many other professional organizations to strike down the current HHS recommendations, and this was just, and the judge just ruled in the favor of American Academy of Pediatrics. And basically what that means is that all of the decisions that were made from June 2025 onward are no longer valid. So I think both locally at the state level and then federally, we're now sort of at a pause at June 2025. And so we just have to go with what was there. Okay, so now I wanted to talk a little bit about some long-term solutions. And this is really to think about, acknowledging that we are now at a point where there's so much public mistrust in the process and in science as a whole, that what can we do in the future to help restore that trust and ensure that our processes work going forward to be able to give vaccines to children. And so I think one of these are just my thoughts, but I think that there's a couple of things that we should be doing. I think we should invest in mechanistic studies of adverse events from vaccines. I think that there's a lot to be gained from looking and understanding what is causing these events. It could help reassure the American public that we're taking them seriously. It could also help us design better vaccines and identify early safety signals before they're licensed for use in the general public. I think we need to do a better job of articulating the value of post-licensure studies, including immunobridging studies. I don't think most people understand that RCTs, though that they're considered the gold standard, are not actually without fault, that there are actually lots of things about RCTs that may not be replicated in real world observational, once the vaccine is rolled out, that you can capture through observational studies. I think we can talk a little bit more about what vaccines can do beyond prevention of infection, and this has recently been covered quite a bit in the news. And then utilize proven methods to sustain vaccine uptake. So in terms of investing in mechanistic studies, so we know that adenovirus vector vaccines led to thrombosis. We knew that we saw myocarditis with the COVID mRNA vaccines in adolescents. Also with the smallpox vaccines, we've seen narcolepsy with the swine flu vaccine, Guillain-Barré after influenza and RSV vaccines. There are lots of known adverse events that occur from vaccines, and for very few of them do we actually have a mechanistic understanding of why they happened. And so I think we really do need to invest in studies that allow us to understand why these are happening. Because if you can find, for example, a marker that you would be able to identify in the clinical trial that then leads to this outcome, then potentially that would be able to allow you to not license vaccines that trigger this marker. And it also, I think, for reasons beyond just science, reassures the public that we actually are taking them seriously. And I think that's important because one of the lessons that I think we learned from COVID is that you can say, you have X number of events of myocarditis from COVID-19 vaccines, but you have X number of events from COVID. But for a parent who has a child who has to get a COVID-19 vaccine as an adolescent male, those numbers are not reassuring to them. And I think we need to do a better job of conveying that, yes, we know this is happening. And here we are trying to figure out why this is happening to make sure it doesn't happen again. And I think those types of studies will help with that. The other thing, and this is just something I'm starting to think through, is just how do we explain to people that post-licensure studies are important? So we know RCTs are the gold standard for licensure. It gives the early efficacy data for licensure, and it identifies these short-term, high-frequency adverse events that tell us to stop the trial. But RCTs also have problems. So they often are done in ideal populations. They often involve people who are highly motivated to participate in research. And once you roll them out, they may not necessarily have the same effect in the general population or in the population for where the mortality is the highest. A perfect example of this is rotavirus vaccine, right? We license rotavirus for use. It's great in the United States. It prevents ED visits and absenteeism, but it doesn't really prevent death. But it has high efficacy for these other outcomes. But then you roll it out to places where there actually is death from rotavirus diarrhea. And in those places, effectiveness is actually much, much lower because of all of these other issues, some of which are starting to begin to be characterized, including mucosal inflammation from probably parasites, breastfeeding. I don't exactly know the details, and I don't know that it's fully worked out why these vaccines are less effective in real world settings, but those are the places that children are dying of rotavirus gastroenteritis. So here, observational studies are done, and then they showed an effect on mortality. And so it's important to have these vaccines for use, but the RCTs actually aren't at all concordant with what we found in the effectiveness studies. Observational studies are also really important because they allow you to evaluate these rare outcomes, myocarditis, for example. And for what I study, which is seasonal respiratory virus vaccines, this is really the only way you can evaluate changing effectiveness with antigenic drift. That you actually cannot run an RCT every single year because it is impossible for so many reasons. But you have to do it using observational effectiveness studies. And then you can look at other outcomes, so protection against transmission, against work and school absenteeism, which may not be the reason for licensure by the FDA. The other thing that I think is interesting and just really starting to be talked about more is the benefits of vaccines beyond prevention of infection to reduce risk of chronic disease. So we know that potentially it's the adjuvant, but maybe it's the vaccine. Shingles and RSV vaccines have now been shown in studies to be pretty definitively linked to prevention of dementia. And influenza and RSV vaccines prevent cardiovascular events, not just in the acute post-infection period, but seeming lasting out to up to a year. So there is quite a bit of benefit. And I think, especially for populations who may be a little bit more vaccine hesitant, having conversations about vaccines preventing cancer, vaccines preventing dementia, vaccines preventing heart attacks and strokes, these are good conversations to start having with your patients. So, okay. So then just thinking about what's going to happen next. I think that there's going to be a continued downward trend in vaccine uptake and public distrust. I think that they're going to broaden the vaccine injury compensation program, the vaccine court to include autism. And another thing I'm really worried about is that we're not actually going to make any progress in reviewing new vaccines or in understanding the adverse events related to newly licensed vaccines. So there's new CMV vaccines in the pipeline that we're not going to discuss. There's a single dose HPV, which may be given even younger than how it's given now. There's a group E strep vaccine, and there's also the Guillain-Barré signal and the preterm signal that was seen with the RSV vaccines that we now have no data about because we have stopped having meetings to assess this. And then what we're also going to see is, of course, an expansion of outbreaks. So measles outbreaks continue to expand. We're probably going to lose measles elimination status this year. And then in Washington State, what you can see here is that this is 2024 data. I'm sure it's even lower now, but this is MMR vaccine coverage by county. And the darker blue means the higher the vaccine coverage. And what I wanted to just emphasize is that there's pretty marked clustering of under vaccination. So for example, here's Yakima County in the middle, 75.1%, but right below that is, I think, Clark County at 47.2%. I may have my geography wrong, but all of those counties that are just abutting Oregon, Cowlitz and Clark, I think, are the ones that now have MMR completion rates in the 40s. And so what will happen is that as children, travel from South Carolina, they travel from Texas, they travel from places where there are ongoing active outbreaks, and they enter these places, you're going to see explosive growth. And even though it's 75% of Yakima County, it's still going to spill over into Yakima County. So we're not really at a great spot right now for where we are with vaccine uptake and vaccine hesitancy. So what can we do? I was trying to end this on a positive note. I think that, so what we do know is that if a recommendation from a healthcare professional makes people up to 10 times more likely to be vaccinated. So as a provider, one of the things you can really do is to be a vaccine champion, to promote vaccines, to support colleagues, to support vaccine policy. I think as the U.S. federal landscape becomes more and more fractured, local and state agencies are going to need support from us. So when they reach out to you and they ask you to provide comment or to help them look at a policy and make sense of things, it's important to be available to do those things. I try to do that as much as I possibly can. I think we know there are some things that do work. So standing orders, reminder recall, vaccine clinics, those work to increase vaccine uptake. But one of the things I'm particularly worried about, and I think, is that you can have all of these things, and at the provider level, at the front line, you can have these conversations with your patients and have all of this trust that's been built. But if all of the messaging that's coming from above is saying vaccines don't work, vaccines cause autism, vaccines do all of these things, it's very hard for us to hold the line. So I do think that there's a lot to be done at a federal level too. That you do need to speak up and talk to your legislators and at the state and at the federal level to make sure that we're doing all we can to provide the voice of this is what vaccine preventable diseases look like once we start seeing them again. Okay, so in conclusion, the U.S. system for vaccine licensure recommendation was the gold standard. There has been a gradual erosion in public trust, and I think there are ways that we can restore this trust through transparent science and also work on legislation. And I think some legislation that insulates vaccine policy making from political influence would be really great if we can accomplish that in the next couple of years, potentially after the midterms. So thank you. These are my references. And then I want to just acknowledge a lot of people that I work with who I talk to a lot about these things. So thank you.
We can open it up to questions in the room first.
Patients out there who might have vaccine hesitancy, do you have recommendations for resources that would be less scientific and that they can read on their own?
Yes, so the question is about resources for people who have vaccine hesitancy to give to patients. Washington State Department of Health has a pretty good compilation of resources on their website in the vaccine section that you can go to, and you can pull things down from there. CDC used to, I haven't looked at the CDC website recently to see what they have, but they used to have a lot of resources as well. And they would have a for providers and then for patients category. It's also, I think, important as, you know, in these scenarios to understand why they're hesitant and what their concern specifically is, because it could be something as, you know, oh, I talked to a friend and they said this, and there's a certain way to address that as opposed to, you know, it depends on where they are and why they're hesitant, what kind of resource you want to give to them. So thanks. Chloe?
Extraordinary. Thank you so much. I think one of the things that you have done that's been very impactful is maintain a relationship with several vaccine hesitant people in our region, and I just wondering what lessons you've learned from them.
So the question is, or the comment is that I've maintained relationships with vaccine hesitant people in the community to through the years, and whether there are lessons to be learned. So I think that that's a, I mean, I think the people who used to be vaccine hesitant are no longer the people who are vaccine hesitant now. That used to be a fairly small group of individuals who are sort of very, very dug in and had a set of, I think, misbeliefs that we could do nothing about. You know, mitochondrial dysfunction, a lot of things that were just, you know, it was important for everyone to continue to have open dialogue, but I don't know that there was anything we could do to change their mind. And so for me, I think those relationships were important because it allowed it for us to have open dialogue to understand what each side was thinking. I think the group that is vaccine hesitant now is a much larger, more diverse group than what used to be, and now includes just normal, healthy, or parents of normal, healthy kids who are just hearing things. And I think that's the approach is not the same. I do think that there's a much larger movable middle now than there used to be. And also the political, I mean, it's just, there's just some things that are very different than even 5 years ago. So, John?
Yeah, I was kind of connected to that, in that it feels like you just explained that there's a much larger, highly financed infrastructure that is supporting misinformation, the spread of misinformation, disinformation, that overlaps with many other things, including the selling supplements, but also the political sphere, and I guess and is actually creating a separate universe around like publications, like false journals and bad studies that are being pointed to. And I guess I've always struggled, and maybe you can't answer this, but it's more like, do you have any sense of like where is this coming from? Like, I mean, it's a lot of money. Is it who's supporting this behind all this? Like, what is supporting this huge structure in all these organizations? Is it politics? Is it social movements? Is it just distrust?
Oh, yeah. So the question is really that there is a fairly organized structure for vaccine hesitancy now that is well funded and politicized. And where did that come from? And how is it being funded. I think there is a political advantage to being part of that now that there wasn't in the past. And so probably, I mean, even the individuals I used to speak to, they are so much better organized now. There's so much more infrastructure to support them and their work. I don't know where that money comes from. I don't. I do think that it is highly profitable, and one of the things that I think the general public doesn't understand is that the people who are who have these messages about vaccines and how vaccines cause harm, they're not necessarily there because they genuinely believe that. For them, this is a fairly profitable endeavor, and so I don't know how to even do anything about that when there's such a national platform for it. I think we need to shut down the national platform for this type of information to be amplified in such a way. I mean, the fact that Nurse Vicky is on ACIP is just shocking. Yeah.
Thank you for all your work.
Yeah.
As a follow-up to that question, I feel like it is fairly clear in a lot of scenarios that a lot of the individuals pushing the anti-vaccine sentiment don't necessarily push it because that's what they genuinely believe. They don't push it because they genuinely believe that it will improve the healthcare of the local community or local population. It is for profit, it is for political power, etc. You talked about a little bit about how there is clear money supporting it. Are there resources that we can point people to that kind of outlines that financial component of it? Because in discussions I've had with a lot of individuals, like my own family members even, they always say, well, medicine's just trying to make money off people. They're trying to keep you sick so that they can sell you the cure. And like it's the money component that talks to them. But I haven't been able to necessarily find big resources in terms of the finances supporting the anti-science movement. I'm sort of curious if you have any insight into those.
I don't know about any public resources so the question is about, is there any transparency into the funding that supports these organizations that are clearly motivated for profit and political gain rather than for the health of people? And I don't know. I mean, I know about sort of the support systems that are in place for RFK's organization, Children's, I think Health Defense or it's Health Defense, right? Yes, health. There certainly that information is available, but I don't know about the entire underlying infrastructure that supports this. I don't know if it's publicly available, but that would be something to work on. I do feel like that side is extremely well organized, and we are not as well organized. And I think we have been underestimating their organization and their influence and their ability to choose the right message. And that we as providers, I feel like have for the longest time just felt like, well, we're the providers, people will listen to us, but I think we have to get much more sophisticated with our messaging.
Many questions in the chat here. One is, they say, I think the rationale for Kennedy and his group have given for the reduced vaccine schedule is that the Netherlands or maybe Denmark, okay, has the reduced schedule. They say, however, in an article I read about this, this other country does the lesser schedule for financial reasons, and they feel that this is that maybe this is a compromise for the smaller population. How do we get this information out in the U.S.?
Well, I think that every vaccine schedule is going to be specific to the place that you're going to administer the vaccine. So, for example, MMR is given at 9 months in low and middle income countries because babies die of measles. Well, they do here now too, but they and so the benefit of getting the vaccine earlier as opposed to later is outweighed or outweighs the potential lower immunogenicity of getting an earlier vaccine. So when you look at Denmark versus the United States, they're just completely different places. Denmark has the population of New York City. The United States is not that. And Denmark has universal health care, has universal everything. And so to apply schedules that are in other countries to the United States just doesn't really make a whole lot of sense because we're not, we're just not the same. And you really do need to protect the people who live in your own country. So that is the nuance of national vaccine recommendations.
Another person asked, some people fear that the pre-2025 vaccine schedule for their babies because they feel that it's too many vaccines given at one time. Is there any data showing harm or serious side effects from giving this increased number of vaccines compared to what we got, say, back in the 1960s or 70s?
Yeah, so the antigen content of the new vaccine schedule is actually lower than the antigen content of the 1995 schedule because the purity of the vaccines has gone up tremendously. So the number of, I guess, pieces of exposure to an antigen are lower than what we've gotten in the past. So I think that's something that I often point to is that you actually you're getting better, more precise vaccines now than you got in the past because we were giving a lot of more, whole cell vaccines, and those just had a lot of other adverse events associated with them.
Another person gives you props for a terrific presentation and a thank you. Would appreciate your perspective on the formation of the multi-state GPS like the West Coast Alliance and the Northeast States Coalition, including how their work at the state level can be optimally coordinated and help us while these sort of national policies are so derailed.
I don't know as much about what's happening with the West Coast Health Alliance. I know that they're relying on the Washington State, Oregon State, and California State Departments of Health to put together the guidance, and that most of those recommendations are being informed by the professional organizations. So American Academy of Pediatrics and AAFP, American Academy of Family Physicians, are sort of the backbone for those recommendations, and then also some organizations that cover specific populations like pregnant persons and immunocompromised patients. So I think that if you want to harmonize, the way that it's being harmonized is basically using the professional organization recommendations. That works for what we know now. It doesn't work for what will happen in the future. So like if there's a new safety signal, I don't know how we're going to find that because there's no way for that data to be presented in some sort of public platform so that everybody can make a decision based on the new data. So that's the problem, is that this only works for a short period of time. So.
One other quick question I just had is if you foresee, I feel like I've noticed some shifts to vaccine, especially in pediatrics, a little bit earlier going to more high-risk areas, which used to just be travel, but now it's also
the homish, yeah.
Needed. I'm just curious how you foresee that changing, like some of the landscape of recommended vaccinations, specifically in pediatrics, but then also for like our adults as well, in terms of our recommendations for when we do travel to different areas.
Yeah, so the departments of health usually have pretty updated recommendations based on what their perceived risk is. Right now, the recommendation is that if you live in a county with an outbreak, you can get an earlier vaccine. So if you live in Snohomish County and you have an 11-month-old, I would get their vaccine. Yeah. So.
Somebody in the chat is asking, how have international distribution programs been affected by the U.S. vaccination policy, if at all? And how do you think they will be affected in the future?
I think that there's been defunding, and so that has had an effect more on the funding side for international vaccine programs, defunding of Gavi and other things. But in terms of the recommendations and what is given, so U.S. recommendations are followed for the United States, and often other organizations turn to the U.S. because we often license vaccines faster than other places. But WHO uses its own system. So it has SAGE, which is like the ACIP, and then they have their own system for licensing vaccines. And then the specific countries have groups called NITAGs, National Immunization Technical Advisory Groups, that often follow SAGE recommendations or they create their own. So they'll probably just follow Europe, I imagine, because that would be sort of the next logical place to go.
This is a question that I have. Do you think that there's any role for social media because I feel
Yes.
like the anti-vax movement, they've like taken over social media. Is there a role for like academia
Yeah.
and like researchers to start pushing into that space? And try to disseminate some good information?
Yeah, I think we're really behind. I don't think we're doing that. If you want to do that for your research project and fellowship, I think it would be great. I mean, I don't think we're as sophisticated as they are. But yes, I think any sort of social media. I'm not on social media, but all of the platforms. It seems like these are effective ways to get the messages out. This is how people consume news these days, and so we need to sort of get on top of that. So,
Well, thank you so much. It was a wonderful talk.
thank you.